Welcome to another edition of the Inspired Stories podcast, where leaders share their experiences so we can learn from their successes and be inspired by how they've overcome adversity. My name is Anthony Codaspoti, and today's guest is Dr. Iyad Houshan, Chief Medical Officer at WellBe Senior Medical. They specialize in providing personalized in-home care for older adults dealing with complex conditions. Founded in 2014 and based in Chicago, WellBe is on a mission to change how care is delivered to older patients, ensuring they stay healthy at home. They deliver compassionate, patient-centered services, including 24/7 urgent care, medication management, and therapy support. Under Dr. Houshan's guidance, WellBe continues to grow and help seniors receive the care they need from the comfort of their own homes. Dr. Houshan draws on his leadership background at Alignment Healthcare, Remita Health, and CareMore Health, where he helped achieve a 4-star rating. He is recognized for his work in improving patient outcomes and developing better care models. Now, before we get into all the good stuff, today's episode is brought to you by my company, Add Back Benefits Agency, where we offer very specific and unique employee benefits that are both great for your team and fiscally optimized for your bottom line. One recent client was able to add over $900 per employee per year in extra cash flow by implementing one of our innovative programs. Results vary for each company, and some organizations may not be eligible. To find out if your company qualifies, contact us today at addbackbenefitsagency.com. All right, back to our guest today, the Chief Medical Officer of WellBe Senior Medical, Dr. Houshan. I appreciate you making the time to share your story today.
Absolutely. Thank you very much, Anthony, for this opportunity.
So let's jump in. So I see you graduated from Ross University School of Medicine in 1999. And
Correct.
Since then, you've led multiple organizations specifically focused on seniors with chronic conditions. Tell us, Doctor, what initially drew you into the field of senior care?
Yeah, so I kind of started my career teaching at the University of Nevada School of Medicine. And this really helped me kind of deepen that knowledge, retention of knowledge, enhance critical thinking skills, and really improve on communication skills, strengthening diagnostics and clinical resourcing, and also develop leadership and mentorship skills. Then from there, I kind of cut my teeth in Medicare Advantage health plans, where I joined, CareMore Health Plan, which is a Medicare Advantage built CareMore Health Plan of Nevada from the ground up to be a 4-star health plan less than 2 years. For the folks that probably on the health plan side, they will understand the challenges that you have to go through to really achieve this in a short period of time.
What were some of the big ones?
Some of the big ones is you're actually trying to get into finding the right network that will support your care model. And at the time, CareMore was a unique care delivery model that is run by the health plan. So you have to find the right clinicians, the right primary care, the right specialists, the right network, the right home health agencies. All of those need to be aligned for you to be able to deliver the right care to those patients in a short period of time. And we're talking about you go in and you probably end up with, let's call it 6 different, let's bring cardiology as an example, 6 different cardiology groups. You got to do the homework and try to study and make sure that those groups are going to provide the care you intend for your patients, because not all of those are created equal. And that's similar to every other network per se. So putting that together and making sure that in the process you're delivering on the promises of those patients who said, I want to sign up for this health plan, and they promised all of these benefits and all of this care. So you want to make sure that you stay true to that statement while building the network, to the specifications that you really would want for a family of yours.
And so what state was that in? Was it a 1 or 2-star, 3-star when you first came in?
We started in Nevada, in Las Vegas. And then from there, we actually ventured into Arizona. That was the second state where we actually ventured outside. The 2 states we ventured outside of California.
But what was the star rating before you came in, or did it not have one? I'm just
When
trying
you
to get an
start
idea of
your
how much you increased it by in those
Yeah,
2
the
years.
star rating there, you get fathered into a 3, and you got to
Okay.
make your work, into a 4, and that's kind of the delta. And when we talk about star rating, PDAS and quality measures are normally very hard to accomplish, and this is kind of where the government told us those are the quality measures that we're going to be really grade you on. And they're actually excellent measures. So you know how when you go, for example, to the hotels, right? There's a 3-star hotel, a 4-star, and a 5-star. When you go to a 3-star hotel, you have certain expectation versus a 5-star hotel. This is the same thing as the services that you're going to provide, the quality of services you provide to your patients. And normally the patients who are joining Medicare Advantage, they start, now this is not a health plan. What I gave you the answer is like mainly on the health plan side, but the patients will come in at probably at 2.3, 2.5 stars, meaning that this is a sick population and there's a lot of work that needs to be done to make sure you close all of these quality gaps from, let's call it, colonoscopies, breast cancer screening, medication adherence, which seems to be the big one that you have to go through. So those are some of the challenges that you would get to get them to a 4-star. Now, the STAR program is bigger than HEDIS, and it has a lot of technical terms here, CAPS and HOS. It's patient care gaps, and also more of objective service measures where we ask the patients, after you being with this health plan for a year, do you feel like your healthcare has improved or not? Do you feel like your well-being has improved? There's a lot to it than what I just mentioned. I just wanted to bring up those examples just in case we have any experts listening to us. It's a big program, and I'm just trying to highlight certain pieces of it.
Got it. So you started out in Nevada, you went to Arizona. I believe CareMore is a lot bigger than that today, right? It's grown quite a
Correct.
bit.
They're bigger. There are multiple states, and the model has changed since. And that's what was CareMore. Then kind of taking some of those learnings from CareMore, went to this other company where we kind of founded, try to get into Cole Health Essentials, get into hospice and medical group. So this is a hospice where we're about 7 states. 7 sites, 3 states, and about 1,000 patient hospices. So if you think of a hospice, this is a medium to high size, normally than the few hundreds, but 1,000 gets you into the medium size there, and 7 sites. We also had a medical group with about 170 clinicians, and at the time we built a model to enable taking risk for dually eligible patients and long-term care patients to establish, palliative care program. Now, when I say dually eligible, so those are the folks who, in California, we call them Medi-Medi, and it's like you have Medicare and you have Medi-Cal in California, or Medicaid. So you're eligible for a state support, also for the CMS support as well. And normally, to get into that, you probably have propensity to be sicker and have a lot of issues aside from chronic conditions. There's a lot of psychosocial issues that you really have to address to be able to manage this population properly. So the example I give for, you could be sitting down with a patient, and I can talk about diabetes for hours, but the patient is worried about they can't afford food, they might be evicted, there's no home for them, and they're worried about paying rent. Until you address those issues, would be
Those are
very
big
difficult
stresses.
for the patient to pay attention. It's like how do you expect me to say, well, these are all the following, for example, diets you have to be on for diabetes? They're like, I can't afford that. I really can't afford. What are you talking about? So then you got to be more innovative, and that's a funny learning I had. I'll give you a story. Is at every juncture you have tons of learnings where, one of our nutritionists taught me. I never knew that there's a quote unquote healthy menu at every fast food place. But there is. It's like, you could come up with, you go to McDonald's, you can make some choices healthier than others. And any other fast food place, they have that. So that actually made a big difference when we talk to our patients. You say, here's some options. Because most of us, I was one of them, the folks like, really? Healthy and fast food, they don't go hand in hand in the same sentence, but it's there. Now,
it's healthier, maybe not as
yes,
healthy as you want to
exactly.
get, but working within the realms of their world and what's accessible to them, you
Exactly.
can help them make better choices.
Right, right. And then from those, from all those experiences, kind of took all those learnings and insights, kind of, seeking, really trying to answer one question: what do patients want? This is how we came to find WellBe. So today, when we talk about WellBe, where we are now, we're like the largest independent home-based medical group in the country, and we're providing transformative outcome-based care for Medicare Advantage. We're about 150,000 plus patients, 9 states, and revenue a little over $3 billion. Now, taking all of that, all of those learnings is when I say, what do patients want, right? Today, if you look at our system, we have one size fits all. If you have problem A, the solution is B. And if you have this issue, you go to that. So it's more of a very rigid workflow type of stuff. But in humans, that doesn't really work, right? So we're trying to attend to their unmet needs. And there's a lot of those unmet needs. If you ever go to the hospital, I don't wish it on anybody, but let's say you go to the hospital, you probably have to tell your story to 6 or 7 different people before you get admitted. Now, what happens is just telling the story over and over again, you tend as a human to omit a lot of information because you're tired of saying the same thing over and over again. And with that, you omit important information that could be, pertinent to the care that you should receive at a hospital. The other thing that we found in our systems today is that at the time when people are sick, fragmentation gets worse. So we have a lot of fragmentation in our healthcare system today. But when you're sick, the fragmentation gets 3x, 4x worse.
What do you mean by fragmentation? Like they're only remembering parts of their health story?
Yeah, well, no, it remembering you as a body part. So meaning that, let's say you're seeing a cardiologist and a gastroenterologist and a endocrinologist. They think of you as a body part. So it's like now you have a cardiology problem that I really want to go and fix, whereas there's many other systems to go look at holistically at the patient. But when I get to what the patients want, most of the time we never start by, what are your wishes? What would you like for your care? How is your care? How do you want your care delivered? We're mainly actually telling the patients what they should do versus knowing what their unmet needs and try to match it with the services that we have.
So that's interesting. Yeah, I go to a doctor. I sort of expect them to kind of guide and run the show. What would be an example answer that I could give back to a doctor about what I want from my care? I mean, at a base level, I want to be healthier and I don't want to be here. But like, what would be some feedback that you get from your patients on that question?
So some of the things that when you ask like an open-ended question would be, let's say, what are your healthcare goals? What do you want? So you could bring it down. So that's very broad. And then you bring it down to, okay, I have a patient with, let's say, severe congestive heart failure. I know that this patient probably based on the stage of their chronic illness. When I ask them, what are your goals? And this patient comes back and tells me, I want to be around for college for my 2-year-old grandson. I want to be around for that. I'd be like, okay, that's a great goal, but with where you are, we probably have to readjust expectations. And it could happen, but we gotta just readjust. And you start the conversation by really having them understand their disease process and understand how these chronic conditions will evolve over time. Because we in medicine, we can manage symptoms for chronic illnesses. We can decrease the slope of progression of a chronic disease, but I can't prevent it from going, if there's nothing else, and if you live to be 150 years, you will die from that chronic condition eventually. So that's kind of, level setting of what are the chronic conditions. However, we tend to go and to say, yep, your diabetes is very well controlled and stuff. We never talk about What else? Right. Or your diabetes is not very well controlled. I'm going to try to control it today. But what are your goals? What are your personal healthcare goals? And how does that fit in your life goals?
So the whole model is complete care at home. I think you've actually trademarked the term complete care. Can you walk us through maybe a real world example where you've kind of seen this this mission of complete care at home come alive for a patient?
Right. So the complete care, you could also call it when we try to attend to the patient's physical, psychological, spiritual, and emotional needs at home. That's complete care. Somebody asked me, and I'll get back to a little bit more specifics on your earlier question, but this just came as a thought here. Somebody asked me, what's the difference between internal medicine and geriatric care? Because we provide geriatric care. So this is a little bit highly clinical, but folks will probably understand what I'm saying here is like internal medicine, I'm an internist and a geriatrician, but internal medicine, we actually try to tend to manage chronic conditions and to manage the numbers and the metrics within the chronic condition. In geriatric care, we try to manage your functional capacity, meaning if my patient is getting up, walking around, walkie-talkie, they're doing their daily activities, they're comfortable, they're no pain. If they're doing all of that, I can actually be confident that their chronic conditions are well controlled. So try to look at your functional capacity as a surrogate of how well your chronic conditions are doing by looking at it holistically because they all interact with each other. Right. So, you said an example would be when I go talk to the patient, sometimes, we say, what do you want today? What do you need? And they'd be, what do you mean? You're a doctor. What can I have from you? I said, tell me, I can change a light bulb for you. What? Yeah, I can. I can figure that out for you. Seriously? Okay. And then we get into more of here's all of these needs, right? And that can get to be overwhelming, but you can go through it, really understand it, stratify it, and make sure that, here's the top things that I can help you with, right? And then we can get into you as a person first before we get to your chronic conditions and disease management that we're going to work on. So mainly asking the open-ended question with the patients, like, what do you need? And you can get several different reactions to that, all the way from shock to very specific needs that you may or may not be able to really address or help. But just the fact that the patient's sharing that with you, that's creating the trust. That's what you need in healthcare to be able to manage, because we have to trust that the patient will take care of what we ask them to take care of, and they also have to trust that we're giving them the right direction to get there and be there for their full journey in healthcare.
Do you only see patients in their homes, or are there times where you visit them sort of in the hospital before or after you've sort of taken over their at-home care?
So the main care we provide is what we call this tailored care at a familiar setting, and that is a home. But when our patients end up going to the hospital, go to skilled nursing facility, or if they end up living in an independent living or assisted living or board and care, we see them there. So we follow the patients to home, whatever they call home. But even in acute episodes, we try to follow the patients to help them during their hospitalization, or if they're transitioning between hospital and home in a skilled nursing facility.
So you'll obviously see them when they're in those more needful situations. You'll see them at home. Do you act as their primary care physician as well by visit them in the home to kind of provide that, I don't know, the routine physical or checkup?
Yeah, we work very closely with the primary care physician network. So we don't like to add another way of managing those patients. So we work very closely with the primary care physicians. Now, we try to provide geriatric care. So we work very closely with the primary care docs. Now, some of our patients, they say they want us to be primary care. We'll assume that. But for the most part, if they have their own primary care, we'll collaborate very closely. And then we become the eyes and ears for that primary care in the home. Because there's one thing that's quite important. When the patients come to us in the office, I'm in an office, they come to us, they probably will get in there, they get dressed, they get ready, they're all looking great, they show up in a very clean, neat environment, they show up to the office. You don't know how they got to where they are by looking at them in the office. When we go to the home, you actually see healthcare in color.
Mm.
It was black and white before, but now it's in color. You see everything. You go in, you go to their homes, and you say, "Wow, look, your bed is too high." I mean, I saw a patient where, I'm not a tall guy, I have to admit, but I saw a patient who's a little shorter than I am, and then the bed was high, and I'm like, "How do you actually get into that bed?" You know? And literally, she was like, "I gotta jump on the bed." So it's a risk and no one paid attention to it. So we try to be very curious. When we're in the home, we look in the kitchen, we look in the patient's, showers and bathrooms and stuff, and we look for any fall risks. So we try to manage like that home environment because that's what got them to where they are today. We open up the fridge, of course, with their permission, with the pantry. What do you have? Right? So all of this to say is when you get in there and you try to see the patient in the home environment, there's a lot of information that you will gather that you're not going to see in the office. So that's where I said you will become that eyes and ears for the primary care in the home. And it's best when we have that, what I call best practice, where I go to the home, I'm not duplicating care in the home. If things the primary care is doing, we'll build on that. And if things that we're doing and the primary care is not, we'll let them know, here's what we're doing with the patient. So that's kind of more of a collaborating on the care to really get to, at the end of the day, what do patients want, what do they need, and attend to those unmet needs.
And so what kinds of specialists are you sending into the homes? They're doctors, nurses, occupational therapists?
We have doctors, we have nurse practitioners, we have social workers. We also have licensed social workers, and those are the folks that focus on behavioral health as well. We provide, all kind of services in the home. We provide Quick Medic, which is an emergency services for the patients at home. And those are paramedics that would go and attend to the patient's needs when there's acute care episodes. We have our nurses that would go to the home and try to provide all the care as well. So it's a multidisciplinary team that they have pharmacy support, they have behavioral health support, and try to, again, that body, mind, and spirit. So try to cover everything for the patient in the home. If there are services where we don't have our folks to go, we can get, for example, home health to go out and help us with physical therapy for some time. We can have them go to wound care centers if needed. So, but our employed WellBe team does the majority of the care for the patient at home.
So, doctor, with your track record of launching hospitalist programs and new care models, I'm curious, what innovation at WellBe Senior Medical are you most proud of?
There's quite few. I think our patient-first mentality is the biggest. Is we're building around the patient. So we're going after, patients' needs. That's one of our biggest differentiators. So we build the tools and resources and the staff and the training to be able to attend to those patients' needs. So that's, kind of most places you already have models that are built and you try to make the patient retrofit into the model. We're actually building it around the patient. And in this case, our families of our patients are our patients. When we say that unit in the middle, it's patient and family together. So if I'm to call one thing would be that is one big differentiator, providing access 24/7 to the patient. We actually have providers that take call for the patients 24/7. It's not 911 or it's not like, call the emergency room It's a live provider, not an answering machine. Pick up the phone and talk to the patient directly.
Wow.
Now, there's been a lot of studies out there when they say, why most of us call 911? If you think of it, why do you actually, when in need, you call 911? The main reason is you get a live person. You got a person to talk to. So we try to emulate that here at WellBe. You call us anytime, you're not going to get an answering machine. You're going to get a live person to talk to. And this person is a provider, could be a doctor, could be a nurse practitioner, and they could attend to your needs and kind of figure out what are your needs now. Now, that's where the human element comes in because, for example, you can have some people say, well, the patient's calling because, oh my God, they took an extra little dose of their high blood pressure medication and they're freaking out. Well, clinically, let's assume it's a very small dose. They took an extra one by mistake. Clinically may not be a huge deal, but to the patient, it is a huge deal. And I got to attend to that. You got to talk them through it, explain, what can be done and make sure that you're monitoring that with them and try to help them through that episode. So again, 24/7 is another big differentiator for us when we provide it. And then finally, providing those acute care episodes at the time of need in the home. We can do a lot of work in the home short of 24/7 monitoring. I can take care of a lot of conditions that the patients have in the comfort of home. So, and I could blurb out, a lot of, for example, clinical things, but I don't know if the listeners will attend to it, but just, conditions that normally would land you in a hospital, but I can take care of at home,
Doctor, you mentioned the human element, and I'm curious because a lot of folks I talk to in the medical field, they tell me how challenging, particularly post-COVID, it's been to find good folks to work for you. And when you find them, to hold on to them. I'm curious what that landscape looks like for WellBe. What are some things that you've tried and found success with when it comes to both recruiting and retaining good talent?
Yeah, absolutely. That's to be honest, that is a challenge. It has been a challenge, and I don't think we have fully solved it yet. However, what we're trying to do is when we bring providers, and that is all sorts of clinicians to come in and join WellBe, we're trying to provide value for the providers. Is one, we're all compassionate folks. We're all here about our patients. So our patient first mission, I think everyone is attracted to. It's like something we do, we're doing it for our patients. But most importantly is that you come a WellBe and you have a higher calling. We're going to address that higher calling for you. And this higher calling by providing certain, training and education that you don't get anywhere else. An example of that is, let's call it advanced care planning. Advanced care planning is a topic, it's been a hot topic for the past 15, 20 years. If you go and look at providers across the US, probably you might be in the less than 55% of folks are comfortable having those discussions. The reason is in medical school, we don't learn that. We learn it day by day. But then what happens is if we don't practice it, then that becomes a skill set that's not built on. So we spend a lot of time on that. We make sure our providers are actually comfortable having those progressive discussions. And it's really not a one and done. It's a process. It's you talk about it. It might take you a year to land as to really understand where the patients are. Sometimes you could do it in one visit. So anywhere in between. So that's a skill set that we provide to our folks. We also provide a lot of education and training around quality of care. And that seems to be, again, a value add to the folks that we get. We've done a lot of work also at the front end of trying to, stratify and be able to filter through some of the candidates from all the learnings that we've had. Because the model that we have is not for everyone. It's not right or wrong. It's just we have providers. The home environment is new. I mean, if you ask many, let's take the doctor's example, many doctors who practice, short of the folks that do geriatric fellowships, we practice in offices skilled nursing facilities, and hospitals. This is where we actually get our residency in. Most of us never make it to the home. And to tell somebody go to the home, it's actually scary. One, to me, it's a privilege because the patients invite us in their home and we have to be able to give them enough value for that. So you see it as a privilege. But, when you go on there, it's intimidating because now
You don't know what you're walking
you're in the
into.
patient's
When you show
environment.
up at your office every day, you know the environment to expect. When you're going into somebody's home, it's uncertain, right?
Exactly. And like I said, most folks will see it's intimidating. What am I going to do? You don't know what to expect, you know, all the way from who's there, the family that's there, and their other, animals would be also who else lives with this patient, you know. It's really intimidating and takes a lot of getting used to. It's not something that you would just show up, yep, I can knock on somebody's door and go on there because you don't know what's behind the door. Um, and how you're going to manage it and handle it. And again, from all of our skill sets that we don't learn that in school. So to answer your question, just like the things that we've done on the front end, filtering through all of this and try to have the right messaging for the candidates that come through to explain that this is a home environment. It's a privilege. And if you don't see it as such, you may or may not, be happy doing what you do. So those are, again, some of the things that we worked on to try to find the right talent, post COVID, and providing the right training for patients is for providers very important because all of us, we learn from the book, we go do practice out there, and we build on that practice. So we try to meet everyone where they are and build on their skills and knowledge as we go.
Is there more scheduling flexibility for folks that are working at WellBe versus maybe a more traditional environment?
Absolutely. There's a lot of flexibility now. We look at productivity. You need to be productive in doing what you do, but you could schedule. You could do your regular life around your patient care. So let's say you have something to attend with your kids and family or something like that. With given enough notice, you could just make your schedule packed in one area, assuming the patients are accepting. And then you'll be able to attend that. So yeah, scheduling flexibility is there, but it needs to be done with eyes wide open because at the end of the day, we value when the patients tell us, I'm coming in, or you tell them I'm coming in at 11, we want to respect that. So it's just that balance between what's scheduled and how to schedule for the future.
So WellBe started either right before COVID or in the early parts of COVID. What was the exact timing?
Yeah, so the company formed as again the entity was formed in 2019. We actually were trying to build around the care model all the way until we launched and we saw our first patient in July 1st of 2020. Now, it's literally at the time, if you recall, I can remember we're actually all in Chicago. There's just a small number of us. We're all in Chicago, and we heard that Illinois is going to close down. They're going to shut down the state and stuff. And I think we did the final run of interviews that we've had. And we all said, we don't know how COVID is going to, what's the effect of COVID or this thing. At the time, we didn't know what it was. It's COVID, but we don't know the implications, the full extent of the implication. And we said, back up, take your stuff with you. We're going home. We don't know how this is going to affect us. Come to find out, actually, COVID was two things. One, COVID actually helped augment, and patients really want the care in their home because they don't want to be in hospitals, skilled nursing facilities, or in offices where other quote unquote sick folks are around. And that was one. But also they really appreciated the care coming to them at home. So you kind of we're attending on them versus they're attending, they're attending on us. So that was kind of, the shift that we realized post. But yeah, we launched in the middle of COVID. And I recall our first training where we're doing the social distancing and stuff and checking temperatures at the door. Folks coming in or trying to do the training, but We had a lot of learnings from that as well. So, yep, we saw the first patient July in Atlanta, July 1st of 2020, and then we saw the first patient in Illinois in August of 2020.
Yeah, really uncertain time. You didn't know what this was going to turn into. Is this going to be good for my business, bad for my business? Did we just invest all this time and effort in putting this new company together just to have it fizzle out? As it turns out, it was, probably a great force multiplier for you guys. People didn't want to go into the crowded hospital systems and be, more exposed. They appreciated the ability to have, WellBe come into their homes and care for them. So this had to contribute, a lot to the growth that you guys have experienced over the last few years. But even as we've come out of COVID, you've continued to grow. How many different markets are you in today, and where do you see that going?
Yeah, we're in 9 states. We're about 150, 160,000 patients attributed to us. And our mission is to deliver this complete care to all geriatric population across the United States. So we want to be across and provide this care to all seniors and anyone in need of our care model out. Our growth has been really on an upslope. It created a lot of challenges as well that come with growth, but what keeps us focused is looking at the results and looking at how patients are satisfied with the services. Like I've been through in a lot of places, but we do surveys every year and through a third party talking to our patients about, how well you're satisfied with the services you're getting from WellBe. We're like 95% satisfied or very satisfied with the services. So when you get that feedback, that gives you is like, I am doing the right thing. We're solving the right problem here. And we just got to double down and keep at it and keep moving in that direction. So, all of those kind of, early outcomes when they come in, they energize, the team and motivate the team to do more of what we're doing as we're refining where the opportunities are.
What is it that I don't know, kind of what's the secret sauce here? You guys innovate, disruptive, like what is it that you're doing that has allowed you to grow so quickly to this point, even post-COVID, and is going to allow you to achieve this mission of expanding it nationwide?
The big thing for us is we've always said, if you take care of the patients, everything follows. That's the secret sauce. We take good care of the patients. But then, what's under that? What does it mean to take care of the patients? I kind of hinted to those earlier. What does it really mean? It's not chronic disease management. It's not utilization management. It's literally attending to the patient's body, mind, and spirit. And that's what sounds like what's missing. If you put all those together and you manage those patients, aside from everything else I outlined, the tools and resources and the services we provide and everything else, I really believe good care is what's producing those results.
It's that holistic approach that you keep talking about, body, mind, and spirit, focusing on the whole person rather than, hey, my left pinky hurts. It's more like, let's take a look at the whole person. Yeah,
exactly. Yeah, we've had multiple cases where, I'll briefly tell you a story of a patient where, we try to manage her clinically. I think we have excellent clinicians. I came on to the care of this patient towards the end, but very, very sick, very frail, and this patient is sitting in a fetal position, and even if you uncover her, she is screaming in pain. She's got pain everywhere. I mean, your heart drops like, oh my God, what can I do? And, really looked at the patient and I said, okay, it's my mission that I will do anything you want. And this patient looked me in the eye and she said, I'm not sure you can. I said, try me, right? I thought she's going to come back. I mean, if I was probably in her position, I'd say, I need a lot of pain meds. I mean, she's in so much pain, right? Like looking at her, she's really in agony. Um, Come to find out, she has only one thing that she wanted. She had a relationship between her and like her daughter and her son really have a very a very rough relationship. All what she wanted is for us to help mend that relationship so she can see the family again. Now, I'm not going to bore you with the details. That was her wish. We
Wow.
worked on it, had a tremendous, teamwork here to get that. We mended that. Now, guess what? Once the daughter and the son walked into that room, you can see tears in her eyes. You can see that she has no pain. She literally was trying to sit up in bed, which she hasn't done in a very long time, trying to sit up in bed, tears, and. And then subsequent to that, you know what happened? She actually kind of said, I'm actually ready to go. I would like to get some
Mhm.
hospice. She's that sick. And believe it or not, a week after that, she passed on comfortably. But that's the one thing she needed, that, there's that emotional obstacle and social. Once we addressed that, she was able to say, I result, I'm good. I'm ready to pass on.
That's pretty powerful. Yeah, and it goes to show the importance of the spiritual and the emotional side of things in addressing physical care too. I'm kind of curious to hear about the partnership that you've formed with Aetna and how that's really helped WellBe.
Yeah. We have, Aetna was actually our first contract that we've had, and we've established what I call a true risk contract, where what we're saying is we're going to manage those patients and we're going to be at risk for the population that we have. But we're not only going to do it, we're going to do it at a high quality. We're going to guarantee for you to have for all our patients, a 4-star rating or higher. We've been able to deliver on all of that. So that relationship has been very fruitful because we're fully aligned. Aetna wants their members, and to us, our patients, to be getting the best care possible. And we're able to deliver on that best care possible to the patients. So that relationship has been very collegial, coordinated very well. And this is the place where I would say 1 + 1 = 3. So that was more of an augmentation of the services. Thinking of health plan as health insurance, I actually kind of commend health plans like Aetna and others that we contract with, is looking for certain services to really help their members. That's most health plans try not to do that because it's a lot of work and it's something they don't take on. But Aetna was able to take that, head on. It's like, okay, if you're able to provide better services to our patients and elevate the care they get while able to provide on this quality, I mean, there's nothing else that could match that. So it's been very fruitful from that standpoint.
Nice. Doctor, what's a serious challenge that you've had to overcome, whether it's personal or professional, or maybe it combines the two? How did you get through that, and what were some lessons you learned coming out the other side?
Yeah, it's definitely, there's been multiple challenges here. One of them is I actually would give kudos to my family because kind of working with this population and trying to put this model of care together, it took its toll on the family. I actually give a lot of credit to my 2 daughters that I'm very proud of. They're 16 and 13, and also big support from my wife because that actually, without enough support to give me the time to be able to spend and be able to, work with the team very closely and spend the time on the road and all go to all these states, meet all the patients and the providers and everything else. So that was a typical challenge. And that was, in the middle of COVID, and could have actually been, catastrophic had it not been the support. But what helped me through that is mainly more of the transparency, the understanding. Again, I'm lucky. It looks like the patient first mentality also resonated with my family because they're like, we know you're not going out there for quote unquote like pleasure. You're not going out to the beach, sipping Mai Tai. You're out there helping folks like grandpa, grandma, uncles and nieces and stuff. So that kind of was very helpful. But it came to a head, where at a time, if we didn't have that understanding, uh, it would have been really catastrophic. But that also helped me also focus to say, again, looks like there's this higher calling and this is the right direction is where we're heading. So that's kind of, at least one example of some challenges. And COVID, emotions were very high for everyone.
Yeah. Yeah. Very tense time for a lot of people. I have to imagine that, from when you first started up there in 2020 to now here in 2025, almost 5 years later, and considering the insane growth that you guys have seen, that you've probably had to change sort of your leadership style, right? It's one thing is required of you when, you first start and you're a bit smaller. And as you continue to level up, you kind of have to put yourself in different roles, different positions. There has to be less of you wearing so many hats and more of you being able to delegate to folks. Does that align with your experience?
Yeah, it definitely does. And I also believe that there's kind of what we call a startup leadership, and then there's a scale and replication leadership style. Mm-hmm. So in a startup mode, you're rolling up your sleeves, you're in the middle of everything, and you're literally in the day to day, and you're diving kind of micro macro in any given day. But this, knowing that this is not my first rodeo, if you will, in a startup and a scale situation, kind of built this from the beginning, where you got to hire the right teammates that could help you scale and replicate. So doing that from the beginning helped out. So I didn't have to change on my colleagues for their leadership. Kind of hired the right folks who I knew they're going to help me with that scale and replication once we're done with the building. So it's mainly kind of really delegating and finding the right team that could help you get there. And this is absolutely a team sport. It's not a one person. There's in any given day, I'm learning, 60 or 70% of things that I didn't know before, learning from others, but having an eye out where you start with a startup mode and you might have a subset of leadership styles and or skills and knowledge that you would require, and building that, looking at the future, that was very helpful to the point where having had in the clinical leadership a lot of changes, it was like all built in as we went, and that was a lot less disruption to everyone. So that helped out tremendously.
You were really set up for success from the beginning. It sounds like it wasn't like this was a couple of founders and, sort of duct taping things together. It was, we've got a vision from the outset of what this is going to become. Let's get the right foundation in place from day one.
Exactly. And, I think we had it right because our venture capital that actually helped us into launch this, all what they have is all their portfolio is around healthcare. So that was very helpful. Having a CEO who's a physician as well for the company, that helped tremendously, where myself and the CEO were fully aligned. We know what to go after and when. So that's kind of, again, set the stage right. So we're looking out to the future, knowing that, we've all been through all of these experiences, taking those insights and what we call that, take the insights and WellBeize them. Because you could come with an experience from a certain, background. It doesn't fit here. And we learned that early on. It's like, don't bring your old experiences, bring them to highlight them. And let's see how we can actually WellBeize them within the model of care that we're actually building.
WellBeize them. I like that. Define what that means. What does it mean to WellBeize something?
WellBeize it to make sure it fits with our initiatives. It fits within our culture. We have a patient-first culture. We have a culture of transparency. We got a culture of openness, and we have a culture of manage patients first and then think later. So you go on there, you take care of the patient, and then you build processes afterwards. It's like the patient care takes precedence over everything. So that would be kind of, the general example around you got to WellBeize it. And there could be an experience where it worked in a certain situation and circumstantial, and it worked very well. How can I take the bits and pieces that actually fit within the model that we have, without totally without saying, oh, this doesn't fit here, we're not going to think about it. We take all comers, all ideas, all thoughts, all innovations. Let's take those, curate them, if you will, and to say, yeah, those pieces we can actually put together to create this new chassis. That's called a WellBe chassis to build on.
Wow. Doctor, a lot of times I talk to founders, C-suite executives, and they rely heavily on a particular daily ritual, habits that they go through every day that keep them centered and on track. Do you have anything like that?
Yeah, I've improved over the past 5 years on those a little bit, embellished, but there is few things that I live by is that I'll start there and then I'll give you those rituals. So I think of leadership more of a building your team, you give them direction, and you produce results. Those are the top 3 definitions of my leadership. So you build your team, and then you give them direction, you produce results. So my hygienes are, I always have weekend hygienes where I'm looking back at the week prior and see what's coming ahead the week after. So that's kind of more from a managing a day-to-day and managing the calendar. So I'm sure I'm prepared for everything that comes during the week. The other thing is I'm very keen on data and analytics. In the heat of battle, you have a hard time trying to look at numbers. And I probably, anywhere between an hour and a half to 2 hours a day, I go in and I look at all of our dashboards, all of our numbers and everything, just to make sure that, one, I understand it, one, it makes sense, and what are we going to do about it? So trying to do that. Those are kind of, from weekend hygiene and data analytics. Then I spend a whole lot of time, this is weekly, and it happens during the week of, what am I doing strategically? Am I really heading the right direction myself? So I got to reflect, say, okay, is this the right direction? And then the other half of that time I spend on the people that we have. Did I invest enough in the people? Those are kind of, the big things that always top of mind for me. And I keep repeating those on a weekly basis.
So the time that you spend looking at the dashboards, I'm curious if you can think of a specific example, whether it's recently or not. You're looking at the data, you see a red flag, you see something that draws your attention to it. What's the actionable step that you take?
Well, there's one that happened, just this weekend. So I'm looking at the dashboard, and again, I look at it every week, and I looked at it and it's like, this looks very different. Something went wrong here. It's really off, totally off. Like, what's going on here? So of course, my mentors in the past, they said, do not reach out to your team on the weekend. They need their time, but here I am, I'm struggling. What do I do? I mean, there's those things. So I try to really discover the reason for it myself. I could not do that, but I was able to hold tight till Monday morning and literally picked up the phone, spoke with the data person responsible for it. Come to find out, this person was probably 2 steps ahead of me. He's like, yep, we realized this. We just got a new data dump. It's going through our curation and things. So that's kind of the action is I tend to ask a lot of questions, a lot of clarifying questions just to make sure we understand. First of all, is it accurate? And if it's accurate, then what's the intervention? Another example would be You could wake up one day and say, wow, look at this. We have a big gap here between where our goals are and where we sit. And the action for me there is like, okay, on our team meetings on Monday, okay, guys, here's what I found. What should we do? So it's more of a team approach to solve the problem. I could highlight it, but I think the team is much smarter than I am. They'd be able to figure out solutions that I haven't thought of.
If that's true, then you've hired well. You said
Yeah,
the team is much smarter than you are. Yep, that's
they
the
are.
goal.
They are.
In my experience, sometimes our mistakes become our greatest teachers. I'm curious if there's an early moment in your career that maybe seemed like a setback at the time, but actually propelled you forward as you look back on it.
Yeah, this was actually early in my teaching years, where as a new physician coming in, trying to practice medicine in the hospital, I was a hospitalist. I thought I could do everything. I thought no one else knows what I know, and I can actually provide the best care to the patients only by myself. And that actually got debunked very quickly. In my first 4 months of actually practicing, I crashed. Crashed because I wasn't able to accomplish anything by myself. Literally, I felt like I failed my patients. I couldn't do it. And to me, that was the juncture where team is the way to go. I gotta work with a team, even though it's not my own team. To give you an example, in the hospital, as a hospitalist, you could go in incognito, go in, see your patient, and come out and write your note and your orders and leave. What I found it to be more helpful after that incident is like, I gotta get this. There's a lot more people. The nurses spend more time with the patients than I do. They know them probably more than I do. I could spend 30, 40 minutes, an hour, but they're like had them for the full day. There must be some insights in there that I could learn to help with the patient care. So I actually started I go on the floor. Most nurses loved it. Some actually called me out on it. It's like, guys, could you round with me? I want to go see the patient. Can we go together? Can we do this? And then they will say, okay, I'm distributing meds. I'll wait till they do it. So the biggest learning for me was that by myself, I can't accomplish anything, but by the numbers and by having the team, there's a lot more that could be accomplished and learned from. And that's kind of early on, and I've been doing it all along here, is you really gotta rely on your team, delegate, but also, you can delegate and check, right? But you gotta delegate to your team, give them that trust. And like I said, a smart team will outsmart you in a very beautiful way. And that brings me tons of comfort to have the folks actually, accomplishing also their goals and what they want to do in their career. So team is the theme here.
Yeah. Are there any books or podcasts that have been particularly helpful for you in kind of learning some of these lessons that our audience might be interested in checking out?
No podcasts come to mind now, even though in our team meetings, we actually share a lot of podcasts. And we have like learn and share. So they come in with different podcasts. There's several, but there's a book that I read, which is actually, it's a leadership book. Some folks might have read it. Now the title evades me, but I can see it in my library here. It talks about they have 7 little stories, leadership stories. One of them talk about, Marie Curie. The other one about NASA's story. Another like 7 little stories of leadership that every time I go back to that book, every few years, like read a story or two, because there was a lot of learnings from it. And it's called like Leadership in Stories. I can send you the full name later for the audience, for the listeners if they need to. But that's one of the books that's always top of mind for me. I'm currently reading my 4th book on emotional intelligence. It seems to be a topic that I'm interested in, just learning more and more, because if we apply more emotional intelligence with our patients, I think we'll learn more and we'll be more effective.
That's interesting. The fourth book currently on emotional intelligence. And so are you able to sort of synthesize some of these lessons and then implement them or help teach them to the rest of your team?
Yeah, I try to kind of have those learnings and share 2 or 3 things that I learned, and then to me it's up to the team of adopting or not. But I'll continue to remind them of those. The big stories here is, again, sitting across from a patient is also another intimidating thing, because you're like sitting with a person who has a lot of issues and you don't know what to expect, especially when they have family around. I don't know if you've ever been in a room where there's like probably 16 family members and a patient. This is real intimidating, because you got all of these people.
You're on stage.
Look and find out what they're thinking, right? And they're looking up to you, so you got to respect that, and you have to provide that value, knowing when to say, "I really don't know." You shouldn't have an answer for everything. Saying "I don't know" is good. Actually, it brings more confidence. Like, yeah, okay, they don't know this, but I'll follow. I'll come back with an answer. I'll find out what the answer is, and I'll come back to you with that. So, but emotional intelligence, I think we don't do a lot of it with our patients, and the more and more we do it, we can actually glean a lot more from the patient stories to be effective in their care.
Doctor, I've just got one more question for you, but before I ask it, I want to do a couple things. First of all, for everyone listening today, there's probably somebody in your life that would get a lot of value out of this podcast. Go ahead and hit the share button. Send that to somebody you know that's in the medical field, somebody who's in senior care, home care. I think they would probably get a lot of value out of what the doctor has shared today. I'm also going to let people know how to get in touch with you, Doctor. We've got your website, which is WellBe, wellbe.com. We've got your LinkedIn page, which we'll share the link in the show notes, but folks can just search for you. Your first name is spelled Iyad, easy for me to say, Iyad, and then the last name Houshan is Houshan. Any other way that you want to direct people to either follow you or get in touch with you?
Yeah, iyad.houshan@wellbe.com. They could send me an email. More than happy to respond to those. LinkedIn, another way of actually, trying to communicate. And we also have on our website a WellBe that we can offer after the call for you to the listeners to be able to reach out if they have any questions on WellBe in general.
That's terrific. So last question for you, Doctor. As you look to the future, whether you think specifically about WellBe or the larger senior home care industry in general, what are some of the changes coming that you're most excited about?
The changes, I think, there's a lot of industry changes in general. What I'm excited about is actually, so this is more of if you look at the Medicare Advantage world, there's a lot of challenges in the world of Medicare Advantage. And, we could go through, there's probably, multiple things that if you look at MA in general. So we know that, for example, Medicare Advantage plans will decrease by 2.8% nationally. So that's going to be, less care for some of these patients who really love to be with MA. And individuals joining MA is like less by 6.5%, right? A lot of the beneficiaries today, they have only about 34 MA plans to choose from in 2025. It was a lot higher before. So I'd say, things that we're excited about is partnering with Medicare Advantage health plans, helping Medicare Advantage health plans really deliver the best benefits to their patients by applying those care and services at the comfort of patients' homes. That's very exciting to me, because the industry having a lot of changes, and we can go in details. There's the IRA, Inflation Reduction Act, a lot of out-of-pocket expense for the patients. So having, aiding and helping Medicare Advantage beef up those, let's call it the benefits to the patients to make sure that the patients stay in the care of Medicare Advantage and be able to deliver better care at the end of the day to give those patients better days. I think that would be super exciting for me because somebody has to do something here. Like we can't really have a lot of control. We have a voice. We don't have a lot of control of the regulatory changes that are taking place, but we can react to them by easing, let's call it the pain on the patient end, and also helping and aiding Medicare Advantage health plans, provide better benefits to the patients at the point of care in their home.
Dr. Iyad Houshan, I want to be the first one to thank you for sharing both your time and your story with us today. I really appreciate it.
Absolutely. Thank you very much, Anthony. I appreciate the opportunity again and hope to come and talk to you soon at some point.
I'd love that. Folks, that's a wrap on another episode of the Inspired Stories podcast. Thanks for learning with us today.